Hello and welcome to this weekly pelvic perineal literature watch for May 29th, 2026, presented by Erwan Le Rumeur, physiotherapist in Paris. This is for information only, not individualized medical advice. This week, the watch retrieved 59 articles. No single paper dominates the field by level of evidence, but several studies point in the same direction. Functional outcomes after pelvic or urologic surgery are not determined only after the operation. They begin before surgery, are influenced by technical choices, require more precise follow-up than a simple continent or incontinent label, and depend on how the patient is informed and monitored. The editorial line today is continence and surgery, anticipating functional outcomes rather than just reacting to them. We will start with radical prostatectomy using 3 papers on prediction of incontinence, postoperative drainage, and sequencing between bladder outlet procedures and radiotherapy. Then we will broaden the discussion to continence products, overactive bladder, catheter removal, LARS, and outcome measurement. First section, the must-read papers. After prostatectomy, the trajectory matters as much as the status. The first paper to highlight is by Hadjivasiliou A, Kelkar, Sridhar et al., published in Scientific Reports, AI-based prediction of post-prostatectomy urinary incontinence and its impact on quality of life, development and validation study, and the topic is directly relevant to clinical practice. After radical prostatectomy, urinary incontinence may affect up to 53% of patients, depending on definitions and timing. Many prediction tools still use binary outcomes, continent or incontinent. The authors propose a more detailed approach using machine learning models to predict not only the presence of incontinence, but also severity and quality of life impact at 3 and 12 months after surgery. XGBoost models were trained on 2,586 patients operated between 2018 and 2021 and validated on 728 patients operated in 2022. For patients who were incontinent at 3 months, the 12-month predictions performed well with AUC values between 0.82 and 0.86. One point is especially interesting. Early quality of life impact predicted the 12-month course better than symptom severity alone. By contrast, 3-month predictions based only on baseline features were more modest, with AUC values between 0.52 and 0.59. The clinical message is straightforward. 2 patients with the same global incontinence score may not follow the same recovery pathway. One may have leakage with limited daily impact and a favorable recovery. Another may have a similar symptom score, but much greater quality of life impairment and a more difficult trajectory. This matters for preoperative counseling and postoperative follow-up. Saying only you may leak is too limited. Patients need information about time course, severity, bother, expected recovery, and when support should be intensified. The second paper by Zeng, Wang, Ning et al. In the Journal of Robotic Surgery asks a very practical question. Do all patients need a urethral catheter after robotic-assisted radical prostatectomy? This is a single-center retrospective cohort of 217 men undergoing extraperitoneal single-site robot-assisted radical prostatectomy. The authors compare 88 patients managed with a standard urethral catheter and 129 patients managed without a urethral catheter using suprapubic catheter drainage through the existing incision. In the suprapubic group, after vesicourethral anastomosis and a negative 150 milliliter saline leak test, a 14 French suprapubic catheter was inserted under direct vision, and the urethral catheter was removed intraoperatively. The outcomes are early, pain, comfort, and immediate continence after catheter removal. In the unmatched cohort, pain scores were similar on postoperative day 1 and on catheter removal day, but lower at discharge in the suprapubic group. Immediate continence, defined as 0 pads per day within 24 hours after catheter removal, was more frequent in the suprapubic group, 57.4% versus 25%. After propensity score matching, the main findings remained directionally consistent. In multivariable analysis, the urethral catheter-free protocol remained independently associated with immediate continence, with an odds ratio of 3.94. 2 patients in the suprapubic group had self-limiting gross hematuria. No urinary tract infection, urethral stricture, or readmission was reported in that group. The limitations are clear: retrospective design, single center, specific surgical setting, and short-term outcomes. But the paper makes one practical point. Drainage is not a minor technical detail. A urethral catheter has mechanical, sensory, and psychological effects. In selected protocols, suprapubic drainage may improve early comfort and change the initial perception of continence. This does not prove long-term benefit, but it places catheter strategy inside the functional pathway, not outside it. The third prostate-focused paper is by Titus, Riveros et al. In prostate cancer and prostatic diseases. It examines genitourinary toxicity according to the timing of bladder outlet obstruction procedures and radiotherapy for localized prostate cancer. The full title is Comparative Analysis of Genitourinary Toxicity Following Bladder Outlet Obstruction Procedures in Patients Before versus After Radiotherapy for Localized Prostate Cancer. The authors used the Ning X database. They identify 447 patients who underwent a bladder outlet obstruction procedure after radiotherapy and 1,504 who underwent such a procedure before radiotherapy. After propensity score matching, each cohort included 411 balanced patients. The analysis then stratified procedures into minimally invasive surgical techniques and resective surgery. The main result is clear. Patients undergoing bladder outlet obstruction procedures after radiotherapy had more genitourinary complications than those treated before radiotherapy. Risk ratios were increased for stress urinary incontinence 4.29, urge urinary incontinence 2.09, mixed urinary incontinence 2.49, urinary retention 2.38, bladder neck contracture 2.56, and urethral stricture 3.28. For minimally invasive techniques, numbers were limited. The clearest signal concerned resective surgery after radiotherapy. For practice, this is important. In a man with both localized prostate cancer and symptomatic bladder outlet obstruction, treatment sequence may influence functional outcomes. This is not a blanket rule saying that benign prostatic obstruction must always be treated first. It is a reminder that before radiotherapy, urinary symptoms, post-void residual flow, retention risk, patient expectations, and the consequences of later surgery on irradiated tissues should be assessed carefully. Second section, the thematic focus. Functional outcome starts before the operating room. The paper by Nicaise, Meyer, Klyde et al. In the Journal of Endourology broadens the discussion to benign prostatic hyperplasia. Comparison of robotic versus laser. Enucleation of the prostate for treatment of benign prostatic hyperplasia. The retrospective cohort includes 476 patients, 68 treated with robotic transabdominal enucleation and 408 with laser enucleation. The groups are not perfectly comparable. Prostates were larger in the robotic group, 125 grams versus 94 grams. Laser enucleation was associated with shorter operative time, lower blood loss, and shorter hospital stay. Robotic enucleation had more overall postoperative complications, 34.3% versus 19.7%, but no clear difference in grade 3A or higher complications. However, transient and prolonged stress urinary incontinence were less frequent in the robotic group. The final rate of unresolved prolonged stress urinary incontinence did not clearly differ between groups. This is not a radical prostatectomy study, but it is useful for functional reasoning. It shows that technical choices may involve different trade-offs, operative time, recovery, blood loss, complications, and continence. For patients, these are not abstract endpoints. They often define how the first weeks and months after surgery are experienced. Catheter management also appears in urogynecology with Budge, Bhatia, Hatazaki et al. In International Urogynecology Journal, home removal of urinary catheters after pelvic floor reconstruction surgery. The study includes 184 patients undergoing pelvic floor reconstructive surgery. Some removed their catheter at home, while others had it removed in hospital. Urinary retention was less frequent in the primary home removal group, 3.3% versus 27.5% in the hospital removal group. Initial hospital stay was also shorter, 0.3 days versus 1.1 days. Catheter-associated urinary tract infections were more frequent in the home removal group, 22.6% versus 9.2%, but the difference did not reach statistical significance. There was no significant difference in readmission or return to the operating room. The study is retrospective and patient selection probably matters, but it raises a timely question. Which parts of postoperative care can be safely moved out of the hospital? The answer is not purely technical. It depends on patient selection, instruction quality, access to rapid contact, and the ability to detect retention, infection, or abnormal pain. For day-to-day management of male urinary incontinence, Hamilton and McCloy in the British Journal of Community Nursing provide a practical review of the condom catheter. Optimizing outcomes in condom catheter use for male urinary incontinence. The paper describes the condom catheter as a non-invasive option for men who can void spontaneously but need continuous urine collection for comfort, hygiene, or skin protection. The safety points are concrete: correct sizing, secure but non-constrictive application, daily changes, regular penile skin inspection, hygiene, moisture control, and patient or caregiver education. Adverse effects are usually minor but include irritation, maceration, pressure necrosis, allergic dermatitis, and urinary tract infection. Rare but serious complications include penile ischemia, edema, and urethral injury when sizing or application is inappropriate. In a post-prostatectomy pathway, this may look less sophisticated than an artificial intelligence model, but it is highly practical. Not all patients want the same continence products. Some prioritize discretion, others security, others simplicity. Product choice should match leakage volume, manual ability, skin condition, nighttime needs, mobility, travel, and social activities. Management also extends beyond stress leakage. Rosato Di Rocco Scerelli et al. In Autonomic Neuroscience review neuromodulation techniques for overactive bladder. Sacral neuromodulation is presented as the gold standard among available neuromodulation modalities, supported by long-term data on efficacy, safety, and quality of life. Tibial nerve stimulation is less invasive and is generally positioned as a second or third line option after pharmacological treatment failure. Pudendal nerve or spinal cord stimulation remain more experimental with preliminary data in selected populations. The value of this review is not to present neuromodulation as a universal answer. It is to remind us that persistent urinary symptoms after prostate or pelvic surgery may be mixed. Stress incontinence, urgency, overactive bladder, voiding dysfunction, pain, protective behaviors, and fear of leakage. Different mechanisms require different responses. Third section, the rehabilitation angle, measuring, dosing, and following progression. Although today's editorial line focuses on male urology and surgery, two rehabilitation papers are worth integrating because they address dosage and progression. The first is a multi-center randomized trial by Lamberti, Ciardi, Giraudo, and Mio, published in European Journal of Obstetrics, Gynecology, and Reproductive Biology, pelvic muscle training and electrostimulation to treat weak pelvic floor. 42 women with stress, urinary incontinence, and very weak pelvic floor muscles were randomized to supervised pelvic floor muscle training plus SEMG, triggered intravaginal electrical stimulation, or supervised training plus sham stimulation. Both groups received supervised sessions 3 times per week for 10 weeks plus a daily home program. At 12 months, the experimental group showed better outcomes for pelvic floor strength, weekly leakage episodes, pad use, ICIQSF score, and patient global impression of improvement. Clinically meaningful improvement was reported by 65% of participants in the experimental group versus 18% in the control group. The sample is small, but the trial is randomized, multicenter, and double-blind. The second paper by Liu, Windsor, Zhang et al. In Current Medical Research and Opinion is a Delphi study on the dosage of biofeedback-assisted pelvic floor muscle training in women with stress urinary incontinence. 15 experts from 8 countries participated, resulting in 19 dosage recommendations. These 2 papers are not prostatectomy papers, but their message is transferable. Rehabilitation is not simply doing exercises. It requires appropriate difficulty, feedback, supervision, training volume, and progression. The same reasoning applies after prostatectomy. The clinician needs to know whether the patient understands the exercise, recruits correctly, relaxes correctly, compensates, tolerates load, and progresses according to his actual recovery trajectory. Last section, the briefs. First brief, Chan, Suen, Colette et al. In Supportive Care in Cancer evaluated a structured pelvic floor physiotherapy program for low anterior resection syndrome after colorectal cancer. 14 colorectal cancer survivors with LARS completed a 10-week program including education, pelvic floor muscle training, rectal balloon biofeedback, and home exercises. Attendance was 100% and home exercise adherence was high. Median LARS score decreased by 13 points, 71.4% achieved meaningful change after the program, and 63.6% maintained it at follow-up. This is a feasibility study without a control group, but it shows that a structured pathway is acceptable and testable. Second brief. Thews, de Beaufort, McDonald et al. In Pediatric Surgery International studied 41 patients with anorectal malformation and sacral agenesis. At a median follow-up age of 11.2 years, 66.7% of patients aged 4 years or older had used transanal irrigation during follow-up, mainly for fecal incontinence. Clean intermittent catheterization was initiated in 43.9%, mostly because of urodynamically confirmed neurogenic bladder. Anorectal malformation complexity toxicity was associated with use of both transanal irrigation and catheterization. This is pediatric, but the functional message is clear. Some patients require structured bowel and bladder management from early life. Third brief. Amorim de Almeida Maciente, Martins de Silva, Sartori et al. In International Urogynecology Journal published a scoping review of instruments for fecal and anal incontinence assessment. 52 studies and 52 instruments were included. Most instruments were self-administered questionnaires, 34 out of 52, or 65.4%, and mainly assessed quality of life. Few tools included complete psychometric validation, formal cross-cultural adaptation, or objective anorectal motor and sensory function. For surgical follow-up and rehabilitation, the choice of measurement tool changes what becomes visible. Conclusion. This week's papers converge toward a useful message for prostatectomy pathways and pelvic surgery more broadly. Postoperative function is not a simple final outcome. It is a trajectory. Hadjivasiliou et al. Show that prediction should include incontinence presence, severity, and quality of life impact. Zeng et al. Remind us that postoperative drainage may influence early comfort and immediate continence. Titus et al. Show that the sequence between bladder outlet surgery and prostate radiotherapy may affect genitourinary toxicity. The papers on continence products, neuromodulation, catheter removal, and structured rehabilitation add the same message: the pathway matters as much as the procedure. Thank you for listening. Always check the full papers and current guidelines before changing practice. References are available in the description, and see you next week for another edition.